for a while, the Americans felt that the ICD-6 wasn't living up to its standards. It wasn't doing what it needed to do around mental health. So they created the DSM, and that was the Diagnostic and Statistical Manual. And it came out in 1952, 3 years after the ICD-6. It was heavily focused on psychoanalytics. And then in 1960, the DSM-2 came out, and it was closer aligned with the ICD, but it was still open to interpretation, and this caused issues. Clinicians started to disagree more and more about what mental health diagnoses looked like, what was the threshold, and because there was no sort of clear framework, it was down to the opinion of clinicians and almost down to either their status or their ego would win the day, until Rosenhan came along. And Rosenhan in 1973 did a famous pseudopatient study. And within this study, Rosenhan sent his students off to a psychiatric institution and told them, they said that they were hearing voices. And the word that he told them to use was thud. The reason he picked thud was because that word had no clinical association at the time. So he was basically trying to make it as much of a control test as possible. And these people were admitted into the institutions, and then they were instructed prior to going in to act normally. And the idea being that if the mental health institutions were reputable and empirically driven, then those people would be released once they start to act normal. They are no longer sick. And they weren't released. And so Rosenhan had to intervene in order to get these people out. These institutions weren't happy, obviously. And so they said to Rosenhan, send more students. We'll catch them this time. And several months went past, and they would say, we've caught 14 this month, and we caught 5 this week. We caught 16 this month. And on it went. Rosenhan didn't send anyone. I think it might have been to have a bit of a laugh, but it also might have been that the risk of not getting a patient back out was a bit scary for him. And once he came to the conclusion, we cannot distinguish the sane from the insane, and that the DSM-2 wasn't fit for purpose, and that we needed a more criteria-driven framework for working with mental health issues. And that would give birth to the DSM-3. Although this was 7 years later, obviously, there was other clinicians working in the background about how things should be criteriaed or checklisted. And the DSM-3 was more consistent with the ICD. Diagnoses were more criteria-driven. And this worked for a while. For the frameworks for diagnosis were available, and clinicians were able to put that in place. Then in 1994, we had the DSM-4, and that became more focused on impairment. And now we're into the modern age of the DSM, because we're now at the DSM-5. And it's really a good refinement of the DSM-4. However, what has perpetuated is criteria-driven diagnoses. So for ADHD, we have things like inattention, hyperactivity, impulsivity, and most organizations will say it has to be over a period of 6 months. The difficulty with that is it's very hard to monitor someone over 6 months other than self-report or report from a parent or something like that.